Have you read anything about validity in reliability in community medicine? Probably not. Undergraduate validity, reliability. So, distinction you understand that there are five that, like, you two are there. So, you have certain features and you don't have the features of others. So, that's why how you distinct. Your, your features are your content. And that features that you don't have of him is your distinction. And as a whole, or rather, it starts with a construct that you are a human being. Then the content, okay, human being, these are the features. Then you are a human being with these features and you don't have these features of him. So these are the distinction. That's how the validity means that when I am describing you, that I am validly describing you. It's like your identity card. It's not somebody else's identity card. Just few words about validity, reliability. And reliability is, if I describe you and after 15 days, that description is told to another person and he sees you and he matches, then it matters. So, this is with time and with person, the description is matching is the reliability. Terms are difficult, but the concept are not that difficult. When I am teaching you something, after 15 days or after going home when you read the textbook, after 15 days you listen to the description of somebody else, it is matching, then it is reliable. Person to person, over time. Over time, there are certain conceptual issues which changes in the content. But overall, the construct remains the same. He remains a human being. Over time being, there was no moustache, there will be moustache. Now no graying of hair, after 30 years there will be graying of hairs. Okay. But still the discrimination will remain. The discriminant validity. So this is validity, this is reliability. So when the names depend on when somebody is naming this taxonomy. So similarly, like in basic science we call taxonomy, in botany, zoology, we call taxonomy, and in clinical science we call nosology. Logy is knowledge, noso about illness, that is how we diagnose. That we are diagnosing this as this based on this validity and reliability. So we are talking, when we are using these terms, that schizophrenia, this is a diagnosis. Then again, diagnosis is a syndromic diagnosis. Diagnosis of the disorder, there is a brain disorder, disorder of the thought process, disorder of the perception system. Disease is the etiology, a specific etiology. Schizophrenia or any systemic disease doesn't have a specific etiology. There are different hypotheses. Infectious disease is a specific etiology. Enteric fever is always salmonella typhi. So it's a disease. Infectious disease. You see in the medicine book, infectious disease. Rest are disorder. So be it very clear. Where the etiology is very clear cut, then it is disease. Very distinctive. So these five term diagnostic categories, overall broad category psychosis, there are under 5. So there will be separate contents, there will be separate distinction. Like schizophrenia more than 1 month, acute and transient less than 1 month. Even in the names, that discrimination is there. Now I talked about that initially, then the disorder, the systems that it involves. There is the thought process, the perception process, then the behavior. Then comes the pathogenesis. So what is the physiological anatomical area of our thought process. What is the physiological anatomical area of our sensation to perception, primary sensory area, then secondary sensory area, then thought process, that emotion driven thought, that is the limbic system, then the judgment related thought, that is the frontal lobe. So pathogenesis will involve these areas. There would be certain disturbances. And schizophrenia, that the linking is split. The linkage is disturbed. So this demyelination process. Now, demyelination process is a developmental process. It is over time. We cannot revert a developmental process. What we can do is, at the end point of that developmental process, or a metabolic process, or any pathogenesis, where it is ending, whether we can change something at that point. Like hypertension, there are so many systemic processes going on to result a rise in lateral pressure of blood flow within that arterial system. So, now we are conceptualizing that what these things can be. Like heart is pumping, so sympathetic. So, we give beta blocker, less, reduce the pumping. Lateral pressure, there is a fluid, then that fluid is giving the lateral pressure. So, you reduce some volume of the fluid by diuretic. Now, this fluid system, which organ controls this fluid system? One is pumping, another that fluid, which organ is controls the fluid system, fluid balance? Kidney, by filtration and reabsorption. In dialysis, it's only filtration. In kidney, it is the loop of Henle, again reabsorption. So, some fluid balance is, again, the organ comes is kidney. What is causing this kidney system functioning? Which chemicals causes this fluid balance, this fluid filtration and reabsorption? Renin-angiotensin. So, we give a medication in the renin-angiotensin system. So, this is the logic how the treatment in clinical subject occurs. We are not able to pinpoint exactly what is happening. Something, a young age, probably stress more. So maybe heart is pumping more. Okay, young age, beta blocker. Later age, already the atherosclerosis pipe is more. Even after giving that arterial system beta blocker, we need to reduce the fluid load. Give diuretic, keeping in balance of this electrolyte balance. We are not reverting the pathophysiology of hypertension. It's going on within the system. Similarly, in the diabetes, there are certain changes happening in the pancreas over the ages, where the immunological process or the genetic process, the C-peptide, those issues, those metabolic loads. Very difficult for us to pinpoint and very difficult for us to revert it back. What we are doing? We are either giving sulfonylureas to secrete more insulin. We are giving metformin to increase the sensitivity of the insulin receptors for the more uptake and this reduce the load of the sugar. Then some of the receptors agonist GLP-1 or this gliptin and flozin. These are the ways we act at the end points, which we can manipulate by substitution of chemicals. We have a limited armory. We cannot reformat our body. If it is a computer system, we cannot reformat it. We just can change the software system. At this level, I do this correction. I cannot change the hardware. So this is the way the entire treatment system of the clinical process goes on. So either by drugs, by chemicals, or even by surgeries. A surgeon cannot bring a new anatomical structure. They can just remove or make some changes, plasty, by bringing this to bringing that to a close to a similar to that anatomical descriptions, so that the physiology remains closest to the desired. That's how the entire treatment process is planned. So if you think in that way, it will be easier to progress in your life. Otherwise, it will always be mugging up. Here we will mug up certain books. There we will follow the pharma companies. They will come and every day you will tell, sir, there is a new medicine. This is. Okay. You will take that in front of your table and you will write. But if you understand the logic, it will be easier. Like, what are the management of schizophrenia? Suddenly you will have to remember, okay, what are the drugs? Okay, this is this. You are pressing your hippocampus. The hippocampus keeps the things in the short-term memory. Long-term memory goes to the cerebral cortex. So you need to read it just before your exam to decode it. How would it be possible to decode everything just before the exam? So you need to develop your logic system and these connections between all the areas of this grey matter to decode the passwords of this management. Okay, this is the area, I write something in this area. This is the thing, I write something in this area. So what are the ways the process may develop? বাবা কি ভাবছিস রে? মোবাইল নাকি? তোরা লিখছিস না আসলে এখন, সেজন্যই তোদের আরো ডিস্ট্রাকশন হচ্ছে। এই জন্য লেখাটা ভালো, কিন্তু এইগুলোতে প্রত্যেকটা লেখাটা আবার this is more of a conceptual issue. So লেখার জায়গাটা এখানে করাটা difficult. When you will talk about schizophrenia management, we will have to think of that in what way, what we are going to manage. Are we going to revert back the brain into a previous non-schizophrenic brain? It is impossible. We will have to think then what are the presentations and how these presentations at what areas of the brain and through what chemicals mostly. Because all the drug delivery system are manipulation of chemicals. That's what you learn from pharmacology. Others are mainly processes, and others there are coming up certain like intervention apart from surgery and these medications, certain processes, particularly in brain or even in heart, you have learned like pacemaker system that revert back to the system, cardiac pacing. Similarly, in the brain, similar pacemakers like deep brain stimulation, they stimulate certain organs electrically. So the chemical release from the brain is again can be directly stimulated. Similarly, there was earlier electroconvulsive therapy. Like in arrhythmia, this is the direct cardioversion. You give DC shock You stop the heart and you let the heart again start pumping. What happens in arrhythmia? There are so many, all the heart is such an organ, then every myocyte can generate its pulsations. So what happens? All of you can talk. Now, if all of you starts talking, what will happen in this class? That's what happens in arrhythmia. Simple logic. Nothing, uniform output goes out. So there should be either, okay, I am talking, then I will ask you, SNOD will talk, then SNOD will tell AV node to talk, there will be communication, then from AV node to the branches will talk. So that becomes chaotic in arrhythmia. Then there is a shock. Hey, order, order, order. Everybody stops. Then the most powerful is SNOD starts. Then AV node picks up. Then the normal rhythm gradually establishes. So similarly, in electroconvulsive therapy, there is a chaos. By creating a shock, giving a very high DC shock to the brain, all the ECG, similarly EEG, all the electrical activity stop. This is called burst suppression. Like the way convulsion in seizure, epilepsy, sudden burst, then flat. Then gradually it starts picking up. Then by picking up the electrical activity, the chemicals start releasing and the neurons start firing and neurons start synapsing, the plasticity. This is how the management occurs. Now, we need to know certain basic chemicals for certain areas of the brain for their basic physiological functions. One of the major, what are the areas that we are talking about? That in the schizophrenia pathogenesis, we are talking about limbic system. We are talking about the sensory processing area of the parietal lobe. We are talking about the frontal lobe judgment system. So, one very important chemical is dopamine. When there is elevation of dopamine in the limbic system, the abnormal thought processes generated. These are emotion-driven thought processes. There are 6 basic emotions. The most common emotion is the baby after delivering, how the baby reacts. What is the first? Absolutely. Cry. So, the baby was comfortable within his or her milieu, homeostasis within the abdominal fluid system, suddenly delivered in a new situation. So, what emotion that can be? Even an adult cries from what? Suddenly a new situation, what would be the emotion? Even in a new environment. Even for you, you are comfortable and suddenly you went outside. New environment, what will you be? You don't know how to react. You are crying. You are crying out of what? Very good. Fear. Fear is the most basic emotion. Then if I comfort you, you become comfortable after a few weeks. Baby becomes comfortable. First comfort is with the mother, with breastfeeding and etc. Then gives social smile at 5 weeks. So what emotion? Huh? Huh? Pleasure, happiness. Now, so mother is a pleasurable stimulus. If the pleasurable stimulus is withdrawn, what emotion will happen? What happens to you if a pleasurable stimulus is withdrawn from you? Huh? Sorrow. How easy to understand and go about it? So fear, and these are is the kind of a corresponding and just reverse. Happiness, withdrawal of happiness is a sorrow. Now fear is something overwhelmingly new and you don't know what it is. But it is, for example, it is not that overwhelmingly something very new or puzzling, but a new thing suddenly comes to you. Wow. That's your reaction? Wow. It's novel, new things, but it's not threatening. It's not, it's out of your control. Suddenly that bell, ringing bell, which is not very threatening, very overwhelming. It's just small sounds, small colors brought in front of the baby. Baby does like this. So what emotion? What emotion? Yeah. What emotion? What emotion your emotion comes? If suddenly a relative comes to your home, you didn't expect the person. Huh? Exclamation. Very good. The fear exclamation. When the new things is overwhelming, then it's fear. When the new thing is okay, comfort is exclamation. When a pleasurable thing comes, it's pleasure or happiness. And the pleasurable thing goes away. This is sadness. When an unpleasant things repeatedly comes and disturbs you, what is your emotion? Huh? Initially it doesn't happen. If I see somebody is not attentive, somebody is talking something, I don't shout immediately. Immediately, what is my reaction? Irritation. See, it's irritation at the disgust. I just express, I am not liking this. What you are doing, I am not liking it. Oh, ma, keno birukta korcho? Bhai, keno birukta korchish? I just express, everybody expresses this disgust and the irritation. The other to whom the stimulus is not being stopped by that disgust and irritation. Then the anger to stop that stimulation. Hey, go out. Stop. So these are the six basic emotions, and emotions related behaviors and thoughts which come out from our limbic system. So you just think, what happens in schizophrenia? Is fear, persecution, somebody is harming me. So excess of my fear, so excess of dopamine. So all these things is excess. Fear excess, either when I am happy, I become excited. Or when I am fearful or sad, I become agitated. What is happening? What is happening? I am not calm. Then again, these things are dopamine is increased. But if the dopamine is decreased in the frontal lobe, then I will not exclaim. I will not be happy. To any novel situations, it won't be something of my pleasure. I will not look out for anything. So I will be withdrawn. It won't produce any pleasure in me. So excess of dopamine will cause fear in me, excitement in me, anger in me. But reduction of dopamine will cause kind of lack of emotion in me, apathy in me, lack of drive in me, avolition in me. I won't reach out. I will not feel pleasure, whatever, I am indifferent. I will not take care of myself. So for an insane person, you see both the presentations. Somebody is coming and hitting you out, and somebody is doing it and going down and going down. So how you manage? You cannot, the both side of the sword is cutting you. One is dopamine is going high, another is dopamine is going down. So how you can handle? That's the crux. That's the area. One is not sleeping at all, another is sleeping whole day. Not being productive. So both sides are very problematic. So you will have to manage both the sides. So you will have to think in that way. Like Parkinson's disease, it is substantia nigra, dopamine production is reduced. So we increase dopamine. There is no confusion in it. After this prolonged external dopamine use, there is supersensitivity of receptors, then some on and off effect, so some receptor sensitizer like metformin, we give amantadine, MAO-B inhibitor and the anti-glutamate actions. Okay. But here, dopamine excess will also produce symptoms, dopamine reduce will also produce symptoms. That's a very complex situation. And the presentations are also called in a different way. First presentations are the positive symptoms. Positive means present. So excess of these symptoms are positive symptoms. Negative symptoms, deficit symptoms. So those are they are not showing their emotions, they are not talking, they are shouting, here they are not talking, they are not interacting, they are not socializing. Here you can put down notes. Positive symptoms, negative symptoms. There you need to give medication. How you do this management? So what I am targeting for? Am I targeting for excess sleep or I am targeting of less sleep? Am I targeting to enhance more interaction or coming him down? The positive symptoms coming down. Negative symptoms then elevating. So the first prototype of antipsychotic drugs were taught in pharmacology. But how they evolved, the logic was first is dopamine blockade. First drug was chlorpromazine, then they came haloperidol. But the problem was, one is lack of dopamine, Parkinsonism. So you cannot give dopamine supplementation as in Parkinsonism because it will increase psychosis. So you give anticholinergic to give acetylcholine to keep the dopamine and acetylcholine balance to reduce the rigidity and tremor. Okay, Parkinsonism managed. But reduction of dopamine in the frontal lobe, the negative symptoms increasing, we are causing iatrogenic negative symptoms. They are becoming dull, they are unproductive. Then came a drug. So we will indirectly enhance dopamine. We cannot directly increase dopamine. So the similar way in Parkinsonism, this balance, this dopamine and acetylcholine balance was managed. In behavioral disorders, dopamine and serotonin was tried to be balanced. If serotonin can be reduced, dopamine gets enhanced. So then the classification of antipsychotics, typical, atypical, you were taught in pharmacology. Typical antipsychotics were only dopamine D2 receptor blocker, which directly produces the Parkinsonian symptoms. The atypical antipsychotics are the serotonin dopamine antagonist. So they do the dopamine antagonism at the limbic system, and the serotonin antagonism is the frontal lobe to enhance the dopamine indirectly over there. And some even at the dopamine receptor, they are agonist antagonists. One serotonin dopamine antagonist group has also some agonistic property of at the dopamine. It is the aripiprazole, partial agonist of dopamine. Now, so manipulation of the dopamine system, typical antipsychotics, atypical antipsychotics. Still the negative symptoms not improve. Then you think of, okay, the patient is sleeping more. Sleeping less, I give GABAergic drugs, benzodiazepines, antipsychotics plus benzodiazepines. Sleeping less, sleeping more, what I will be? What chemical causes this sleep? Huh? Huh? Caffeine gives sleep. It decreases. So caffeine inhibition, you mean? That's not caffeine inhibition. So nowadays they are talk about orexin, but another very common thing is histamine. Histamine is reticular, this RAS system, whichever drug has a sedative property, it has a, other than GABA, this is antihistaminic property. Cough syrup, the people sleeps on cough syrup. Or this itching medication, you take cetirizine, you will sleep. So antihistaminic. So some histaminergic drug, histamine agonist, that reduces sleep. This is a modafinil. So for negative symptoms, modafinil. Then this degenerative process, if some degenerative process can be reverted, like what happened in dementia we are trying. So how this degeneration process occurs? Through glutamate. So some anti-glutamate, memantine, which is also used in dementia, Alzheimer's. So one is for positive symptoms, the D2 blocker. Positive plus negative symptoms, this is serotonin dopamine antagonist and modafinil, memantine, and even at times there may be, like apart from positive and negative, some additional symptoms. Like previously, in international classification, this is 10th till 10th revision. That's what I am telling, the content changes. Till 15 years back, schizophrenia used to be said 4 or 5 types. Now that has been abolished because schizophrenia is a lifelong illness. So certain features appear now, certain features appear that. Okay. So today, 10 years back, he did not have mustache. Now he has mustache. 20 years after, he will develop either baldness or graying. So we cannot say types of, what is your name please? Huh? Shom? Shovi. types of so weak. That will be reduced. That the validity got challenged. That is not types of so weak. Then in the cross section it came. In the longitudinal process it happened like this. Now somebody is early graying, somebody is late graying, somebody is no baldness, somebody is more baldness. So that is very difficult to typify. So all the features might happen. They used to say paranoid schizophrenia, they used to say catatonic schizophrenia, they used to say hebephrenic, disorganized emotion system, silly smiling, silly giggling, catatonia, this is a frozen state. There is an undifferentiated mixture of these. Oh, we cannot typify. This patient today paranoid, tomorrow will be undifferentiated. Well, let's forget about it. Schizophrenia. All these features, either in the thought disturbance or the perceptual disturbance or the behavioral disorganized behavior emotions or the disorganized speech and thought. 4 domains of psychosis. Thought disturbance, delusion. Perceptual disturbance, hallucination. Now, disorganized emotions behavior, that was tried to be described as hebephrenia, disorganized emotions, or disorganized speech and thoughts process, that is the logical organization of thoughts, formal thought disorder. So that might happen along the course. So that's not we cannot typify. Rather, we can say what is the predominant presentation. So predominant presentation of positive symptoms, delusion, hallucination. Predominant presentation of the negative symptoms, that is apathy, lack of emotions, asociality, not mixing, abulia or alogia, not talking, not having any interest to work, avolition. So negative symptoms. Then disorganized behavior, disorganized symptoms, presentations, or some other symptoms like limbic system also affect, which controls what? The emotions. So certain emotion systems. The emotional disorders you have earlier taught, affective disorder, bipolar affective disorder, depressive disorder. So some depressive symptoms. Because the same area being involved, no? So certain depressive symptoms might also come. Certain manic symptoms might also come. Even suicidal symptoms might also come. So what is your presentation? You give medication in that. If there is additional depressive symptoms, you give antidepressant. I am not going into details of antidepressant. If the excess of emotional symptoms, you give certain mood stabilizers. If suicidality, then electroconvulsive therapy or another among drugs, lithium. So you think and you write in that. So this is how the schizophrenia gamut of presentation, and this is how, what is the presentation? You made tailor-made. You don't give the entire package, okay, you make a tailor-made approach. Okay, this the presentation is this, I give you this. The construct is same, schizophrenia. It is a dopamine system disturbance. So currently the principal medication is serotonin dopamine antagonist. At least the main 2 core features of positive and negative symptoms taken care of. Risperidone, olanzapine, quetiapine, amisulpiride, clozapine. Don't need to go much detail into it. So undergraduate, not much required. Serotonin dopamine antagonist. Side effects. Now, side effects is dopamine Parkinsonism. Now, serotonin dopamine antagonism, it has been seen that they have antihistaminic property, and through antihistaminic property they have a more metabolic side effects. So weight gain, diabetes, these are the symptoms. Then this dopamine system, dopamine in hypothalamus. What is the role of dopamine in hypothalamus? Can anybody tell? Over the posterior pituitary. Very good. What is the role of dopamine with prolactin? Huh? It inhibits prolactin. So posterior prolactin gets released from anterior or posterior? Anterior pituitary. So prolactin is released from anterior pituitary. So dopamine from the hypothalamus, it is acting as a inhibitor of dopamine release. So if I give dopamine antagonist, then the prolactin gets increased. So hyperprolactinemia, then for males gynecomastia, for females galactorrhea, these can be side effects. So over there again you give dopamine. What is the direct dopamine can be given? Huh? No. Levodopa is usually in the Parkinson's, and another is cabergoline, dopamine, cabergoline. Another is bromocriptine. Very good, very good. So bromocriptine is given when excess of dopamine. This causes catatonic symptoms. This is called neuroleptic malignant syndrome. The excess of Parkinsonism, sudden excess of Parkinsonism and muscle destruction is occurring. So sudden hypothalamus, this hypothalamic set point changes, autonomic symptoms goes high, temperature set point, hypothalamus temperature set point, sudden high fever, then diaphoresis, then this blood pressure uncontrolled either goes high or down, then severe muscle destructions, they are dopamine. And benzodiazepine too. So if the question might comes, NMS, neuroleptic malignant syndrome. That is a excess of the extrapyramidal symptoms. Extrapyramidal symptoms, Parkinsonism is called rigidity. When it goes very high, when the dose is very high, suddenly lot of receptors got blocked. Then this called this neuroleptic malignant syndrome, where the medication is fluid for hydration to reduce the muscle degradation products. Then this bromocriptine as a antagonism to this dopamine and benzodiazepine after withholding the antipsychotics. Extrapyramidal symptoms, this is acetylcholine. This is a central specific acetylcholine. This is trihexyphenidyl, benztropine. This is for galactorrhea. You can give carbgolin. You can give the serotonin dopamine antagonist to such a dopamine agonistic activity. What is that? I told 10 minutes back. Aripiprazole. So you can combine the antipsychotics which has a high dopamine prolactin enhancing propensity with aripiprazole. The two antipsychotics have very high prolactin enhancing propensity. I don't have watch today. What is the time now? 9:51. Okay. So 5 minutes more. So amisulpiride and this risperidone you can combine. And high metabolic side effects are olanzapine, clozapine and cushiapine. And out of clozapine again, another side effect is agranulocytosis. That is a black box warning. Agranulocytosis and cardiac conduction defect. In myocarditis it causes, but apart from that there is a seizure threshold. So this drug may also reduce the seizure threshold. More antihistaminic, more seizure threshold. So in the older generation, chlorpromazine. Newer generation, this is clozapine, cushiapine, and certain black box warning. Do you know black box warning? These are very severe health hazards. They give a black box warning in the drug. So that is myocarditis and this agranulocytosis, where the count drops, that even the absolute count, the total count of TLC goes below 3000, absolute count of neutrophil goes below 900. So this is agranulocytosis. Other drugs might cause, carbamazepine may cause, among the anti-epileptic drugs. So this is how the management of schizophrenia depending on the presentation. Pharmacological management, may electroconvulsive therapy management for this suicidality, then behavioral management. Now, for excess behaviors, it is very difficult to initiate behavioral management. There you need restraint. So, behaviorally you tie somebody is not a good. So, that there you chemical restraint. But where you need to stimulate, that you can do by behavior. So, you can engage them. So, they are kind of the most easy way to engage something is exercise. You call it yoga, you call it music therapy, whatever. This engagement, physical engagement and the brain different areas engagement. Then you can use this cognitive behavior therapy. That the negative cognition is coming, whenever the hallucination is coming, negative cognition is coming, probably somebody is trying to kill you. There you can, nobody is trying to kill you. This is a symptom of schizophrenia. That's why it's happening. Don't get frightened over it. That is a cognitive behavior therapy of schizophrenia. If the patient is treating over a long time, the hallucination is not controlled. But the patient has developed trust with you. So you can challenge the negative cognition that whenever hallucination occurs, that means some persecutor is there. No, there is no persecutor. It's just your symptom of schizophrenia. So don't get frightened. And if this extension of the behavioral extension of the hallucination goes away, patient is much more comfortable. So cognitive behavior therapy for particular symptoms, this might also can be done. So this is management of schizophrenia. And these dopamine system management will also hold true for other psychotic disorders. There we will give it for short time. Acute and transient psychosis, you will give it for short time. Then schizoaffective, you will give from something of schizophrenia and you will give something of mood disorders, mood symptoms. Persistent delusion, again it's a thought disorder system. You give the same medication. The management planning is more or less similar. How you choose, you take the presentation and you give. So if you understand the whole logic of management, you can tailor-made it into different illness and different presentation and different person. Somebody who has come with a diabetes, whatever may be the presentation, you should not give the medications which increase the blood sugar. Somebody who is a young female, the menstruation disturbance, so you should be careful not to, these prolactin disturbing medications you should avoid. An elderly person has come with symptoms of already this movement disorder, so relatively less extrapyramidal symptoms. Least extrapyramidal symptoms are those clozapine, quetiapine, olanzapine, which cause metabolic symptoms. So there you need to balance. So this is the way you tailor it according to the presentation.